Hello, I am Paula Bennett and welcome to my New Zealand Herald podcast, Ask Me Anything. One thing I've learnt in life is it's never too late to learn something new. So on this podcast, I talk to people from all walks of life to hear about how they got to where they are and get some advice and guidance on some of life's biggest questions. And we're certainly doing that today. The state of our health system is a constant focus and is a concern for most of us. We all see it firsthand and are directly impacted by a health system that is not doing its best by us, but only someone on the inside can truly give you the insight into where the crisis in our health system is at. And Ivor Popovich, an intensive care doctor in Auckland, he has worked across different hospitals and specialities for the last 10 years and is fully qualified as a specialist in August. Ivor has written a book. I don't know. It was slightly terrifying reading it, I think. It's called A Dim Prognosis, Our Health System in Crisis and a Doctor's View on How to Fix It. So, Dr Ivor, thank you for joining me today.
Thanks for having me on. Nice to meet you.
It's nice to meet you too. I'm going to ease us in because we've got a lot to talk about here. Okay, so what's top of the bucket list? You've got all the time and all the money in the world. What would you do?
Oh, I'd like to go to space.
Would you?
Well, there's all these people doing, companies doing the trips to space. I think that would be quite fun.
Do you? Yeah. And is it the weightlessness and the experience of just being
being able to see the Earth from up above, and being weightless would be fun too.
Yeah. No, that thought terrifies me, but that's all right. Actually, I normally go, are you a morning person or a night owl? But the first page of your book says that you're not really a morning person.
No, I'm not a morning person at all. I hate mornings.
But you do all nights.
I do a lot of nights. I can sleep anytime, any place.
Can you?
Yeah.
From doing night shifts and things. You just have to, right?
I have to, yeah.
Mine's quite different. I used to do night shifts in a truck stop.
Oh, yeah.
Back in my teens. And I'm a bit the same. Anytime I can grab some sleep, because when you're so sleep deprived, you kind of have to. Okay, so we're going to learn a little bit more about you, I think, in this first half. But your book, A Dim Prognosis, is a great read. I found it really interesting. I found it really insightful. And I love that you actually come up with some ideas and solutions as well, because we're all quick to point out a problem, but actually it's what we do. But let's get to know you a little bit more. So why did you go to medical school? What was the drive behind that?
It was just a bit of I fell into it kind of decision. I was at the end of high school, didn't really know what I wanted to do. And my parents said, well, why don't you think about medicine? You're good at science. You can talk to people. So I said, okay, sure, I'll give it a go. And so I went into it and had no idea what I was in for.
That's kind of fascinating in itself, because for most people it's just sort of calling, isn't it? Or they have some incident when they're in hospital with a parent, or they've got a God complex where they think, I can go and fix the world.
Yeah, there's a lot of people who've known from a young age. And in fact, I wrote in my book, I think, that in high school I'd said I definitely don't want to be a doctor, because I'd seen someone in the year above me go into it and they had to sit all these exams and do really well to get into it. I thought that sounds too hard. So I said, there's no way I'm ever going to do that.
And so how long is the training? So, I mean, you're in university for how long? And then, because you sort of hear that 7-year thing, is it true?
So I guess it depends if you enter as an undergraduate or a graduate, but it's a minimum of 6 years in university. Then once you graduate, you do 2 years as kind of an intern going around different things. And at that point, most people will choose to specialise in some specialist. That could be GP, or it could be surgery, it could be anything. And that's then training program is probably at least 6 years for most things.
And for you ended up in the ICU?
That's right, yeah.
And why that particular speciality from your perspective?
I had kind of, during the 2 years where you're kind of an intern and you're going around, I'd always been a little bit fascinated by, to have patients who would get really unwell and they'd be shipped off to the ICU. I kind of had this kind of, well, what happens back there? It's all a bit mysterious. And so I decided to do a rotation in it in my third year as a doctor, and I kind of just found I enjoyed it. It's a lot of, machines and things that are interesting to think about how they work, and I think a lot of very personal interactions with people and families. And it's also just very broad, which I really enjoy. So you can be looking after anything from a pregnant patient to a child to someone who's had an operation. Yeah,
to the heart surgery, which you sort of wrote quite a bit about in there, which, it was pretty much, I sort of touched on it slightly, but it's interesting who does go into medicine, right? And the different personalities and how that kind of works within the system. And you kind of talk about the hierarchy. Trust me, there's a hierarchy in Parliament as well. that goes right through and is part of the sort of bullying culture. But you sort of talk a bit about that in the book. So, but I think like any profession, you've got those that are great, those that are not, all the different personalities within. But do we expect more from our doctors? Do we expect more from our specialists than our practitioners?
Yeah, I think so. I think, as you say, and I've only ever worked in medicine, so I don't know what it's like, and I'm sure it's pretty much the same. You have a small group of people who are with bad behaviour who ruin it for the rest. I think where I think we probably expect more is the people, and I talk a lot about this in A Dim Prognosis, is the people around who kind of are either the people who can facilitate this behaviour by not saying anything about it and turning a blind eye and saying, oh, that's just the way it is, that's just the way this person is, versus being able to actually say, no, that's not all right, and putting some kind of boundaries into place to protect those coming through.
Do you think it's getting better or worse? Because in most workplaces it's getting better, right? You know, like what you accepted even 10 years ago, but certainly what you accepted 20 or 30 years ago, you would not accept in the workplace now.
Yeah, I think to be fair, things are getting better. I think the stories that I hear from people who started 10 years and 20 years before me are much worse than what I had, and some of the stories I tell people who are starting now does seem to be getting...
Yeah, and even some of that, the way that patients in particular treat nurses, and, there's those that due to their illness, or I'm probably being a bit generous, but then, we've heard publicly about staff actually protecting each other with incidences of racism and things, so there is that level of, actually we probably would have turned a blind eye to that years ago, now we don't, which is quite, which I think is quite powerful too. Okay, so let's get a bit into it. So you sort of talk about the pressures of the health system, and you give some great examples. And I know that you've talked with Francesca, and she sort of nailed it for me as well, where she sort of said, you hear all these bits, and what you've done is put them all in one book. Like if you speak to a specialist, or you speak to someone that's in ED, or you speak to someone that works in these environments. So talk me through the harsh reality of working in the public health system. I mean, what's a shift like? What's a week in the job like?
Yeah, I guess so. A lot of this stuff I draw in the book from experiences across various different specialties. I think for me, where I'm working at the moment in intensive care, a regular week, so I would do like a 24-hour on-call once a week, where I'm on call from 8 a.m. till... So
that means you can get a call at any time, or are you on site for that 24 hours?
It depends a little bit where you're working at. So usually on site from until 8 p.m, and then you'd do a ward round at 8 p.m. in the evening, and then you'd be available overnight. And so at the moment I'm living on the North Shore and working in Middlemore, so I stay on site. Yeah. Because it's too far away. If you were closer, you might be able to go home, but you're available. So usually you'd get called 4 or 5 times overnight. Wow. You might have to go and get up and actually go in probably 1 in every 4. Yeah. It's a bit variable. Mm-hmm. I think I'm a bit lucky in that in the ICU, the pressures that I talk about in the system were kind of slightly insulated. Well, we're not insulated, but we're a little bit more protected than other areas are. But I think what I see on a regular basis in the work in the ICU is every day we have patients who've been admitted to the ICU, they've been really unwell. 2 days later, they're better. They're ready to go out. They're ready to head out to the ward, but there's no beds for them. Yeah. Because the rest of the hospital is chocker. There's no beds on the ward. There's no beds for patients from the ED to come into. So we have these patients who stay with us for days and days, and 4 days later we finally get a bed for the ward in them, and we think, well, actually, we could probably just send you home at this point. God. And they're occupying this bed, which is, I can't remember the exact numbers, but ICU beds are about twice as expensive. I was going to say, even from a cost perspective, right? And it's not all about cost, please don't get me wrong. But even from that efficiency perspective and the use of the right sort of ratios of staff to patients and all the rest of it, because I just remember it being something like $3,000 a day for ICU and sort of like $1,200 for, a ward bed, if you like. And it's just, from that level of efficiency. You talk about it in the book, and certainly in that chapter about nurses as well, and just how incredibly understaffed and overworked they are, and how important they are in the system. Talk to me a bit about that. Yeah, the doctors go around and we say, well, do this and do this and do this, and it's the nurses who are spending the majority of the time with the patients, taking care of them, doing what they need to do, making sure that the treatments we prescribe are actually going to happen and work and get the patient better. And I think what we're seeing at the moment, they have ratios of nurses to patients that are considered safe and they're considered able to provide the care they need to, and that's about 1 in 4 on the ward. And you often, as an intensive care doctor, you will go to the ward to review patients there, and you just see, where are all the nurses? There's about 3 nurses looking after an entire ward, so their ratios are 1 to 8, 1 to 9, and you can just see they don't have time to do things. You go through the ED, and I talk about in the book, one of my friends who's a nurse is there, and she's in the triage bay, which is supposed to be the patients come in through the ambulance, they get triaged, they get sent into the ED. There's no space in ED, so she's got 9 patients sitting in the triage bay. She's running around. There's like an emergency call put out in the triage bay, so everybody descends there. She's spend the entire day. She gets one patient into the ED, another comes in, she doesn't have time for lunch, doesn't have time to go to the bathroom.
Yeah.
So I think there's been a lot of debate about, do we have enough nurses or not? I think if you spent an hour or two in the hospital anywhere, you would realise we just don't have enough to do the work.
No. Yeah. And particularly if those ratios are so out, and then how unsafe it is. Is there, with our ageing population, and as you say in the book, we've known this is coming. It's not like it's a surprise to us all that we're living longer and in some respects healthier and then hitting. So is there something in that ageing population with more comorbidities, or, like it's not like you've just often got one thing wrong and that's what's clogging up our health system as well?
Yeah, I think, as I talk about in the book, the over 65 population has doubled, or will double from 2000 to 2030. And it's that age group that really has, and as you say, it's not just necessarily one thing, but it's a lot of comorbidities that lead to people, and a lot of comorbidities which you need good management from a good GP to keep those things at bay in the community, not have them end up coming into hospital. Yeah. But of course our GPs are overwhelmed, they don't have enough time to see the patients can't get into an appointment in a timely fashion, the prices are going up, so they all descend upon the ED to be seen for free. So that is a huge burden. Yeah, it really is. And that it just seems that they take longer to get well enough to go home as well if they are going to be going home, So there's, again, that sort of clog up in the system. And you can sort of see that happening too. Yeah, I think there's I can't remember the exact numbers again now, but there is a percentage, like the majority of our healthcare money is spent on people over the age of 65. And that's not to be rude and say, well, blame anyone for anything. That's just the reality that as you kind of get older, your need for healthcare and your need for us to look after you becomes greater. Yeah, exactly. I mean, we sort of touched on it, but you talk about the sort of culture of some of the problems of the people in our health system. And I suppose I should say my own slight bias. At one stage when I left being the Minister of Social Development, the then Prime Minister said to me, I think you should think about doing health. And I went, no. He went, well, you just didn't give that. And I went, no. and for me as well, it was like, I don't understand it. So, that's the truth of it. And then, but equally, I was just like, my goodness, the difference in staff and the hierarchy, as we sort of talked about, and how that whole system fits together, and with admin, and with needing that sort of management and middle management, and then all of the politics around it, if you like, and then everybody's own sort of expectations all come crashing down into one sort of place, all of which it seems to me don't always talk to each other either. What I did find really quite frightening was you talking about in the book is about people perhaps getting treatments that they don't need because they've been misdiagnosed somewhere through the system. Can you talk to me a bit about that? I guess, that section of the book was talking about, because you have to, in the book you talk about the funding issue and you talk about the culture amongst doctors. There's also importance to talk to the public about what can you expect when you try and, what does, even if we had the ideal system, what would that look like? And that ideal system, even if everything were perfect and perfectly funded, there would still be bad things would still happen because that's just the nature sometimes when you're unwell. I think what that section was talking about was there's this kind of perception that a lot of technology and a lot of scans and a lot of investigations will always are a better thing than less. What I try and point out in that section is sometimes technology can and scans and tests can mislead you because you get this fancy technology which is getting better and better at seeing small things like CT scans and things like that. The problem is sometimes you see things which technology picks up because it's getting better. It can see those small things, but you might pick up things that aren't actually there. So it's not a matter of someone having made a mistake or misdiagnosed. It's just sometimes we get these things which they are really there, but we just don't know what to do with them. So you get a scan looking for one thing, it doesn't find that thing, but incidentally you find, there's a little nodule somewhere in your body, and maybe 10 years ago we wouldn't have picked that up. Yeah. And it would never have caused you any harm, and we would have never done anything about it, and you would have been fine. But now we know it's there. We go, well, hell, what do we do about this now? Do we do some more tests? Do we stick a needle in it to try to figure out what it is? Yeah. That comes with harm anytime you're doing a procedure. Do we kind of ignore it and just follow it up? And then in which case you're living with the anxiety thinking, well, what is this thing? And is this some time bomb that I have that's going to go off, or is this nothing? So that's kind of making the point that more testing and more scans and more technology won't necessarily always be our saviour, because there will, it sometimes creates problems of its own. And you do give some great examples as well about not forgetting the knowledge of your doctor, the knowledge of them using, as you say, and you give that example of, and I'm sorry if I'm not going to do this correctly because, you're the expert, but, of one in your ICU, she's had heart surgery, you're wanting some certain thing to be at a certain number and you're thinking it needs to be more, so you're doing more. And then, the next day her specialist kind of goes, well, hold on a minute, did you, and I mean, there's other examples that you give that are the complete opposite to that, where actually you've made the right call and the machine would have told you almost not to, but you picked up on other things that are sort of happening there. And so are we
we at risk of losing some of that human factor as we rely more on technology?
I think there is an element. You do see that, doctors who've trained in an era now where we have a lot more access to scans and better scans, their skills at being able to hear a story from a patient or examine a patient and figure out what's going on are probably less. I think it's a balance, right? Because you need to...
You need it all,
you need it all.
Yeah, you do.
You can't just rely on one thing. But I think it's a matter of, sometimes not missing the forest for the trees and not getting stuck on, well, this shows actually stepping back and going, well, actually, what is the overall picture telling us here? And also, what is important to the patient? Yeah, absolutely. Okay, we're going to take a quick break and then we're going to come back with how we fix it, because that's what we really, this is an advice, and man, you've got some pretty good and big ideas in here that I think we need to explore. Before I go to the break though, I've got some good news for you. I know for a fact that quite a few politicians listen to my podcast, so we can speak almost directly to them and see if we can make a difference there. We'll be back shortly. Okay, well, welcome back to Ask Me Anything. My guest is Dr Ivor Popovich. We are discussing his new book, A Dim Prognosis, Our Health System in Crisis, and a doctor's view on how to fix it. So now we're going to focus on how to fix it. Can I also just recommend to anyone out there that you do read the book, particularly if you are interested in our health system, if you're interested in where we are now, where we're heading in the future, and the kind of changes we need to make. And we all need to be invested in this. So anyway, that's my advice. There you go. What needs to be the first focus? You talk about GPs and you've talked about them, that primary health care. We haven't got that model right, do we? Yeah, I think the big picture in terms of everything is just the amount of funding. And I think whenever we talk about any model, whether it's primary care or secondary care, it's thinking about, like we talked earlier, about the needs of the population are growing so much in excess of what we're funding it. And, we know that, for example, in the last year's health budget, if you take into account the inflation and that population growth, our real spending actually dropped. And similarly, because this year we're not kind of going to be keeping up with the amount we need just to stay even and keep everything level where it is. And I think one of the things that's key in this scenario, in this situation I describe is having more funding for primary care, because a lot of the things that end up filling up our hospitals are things that are the really key. Prevention is the key with them. So things like diabetes, high blood pressure, high cholesterol, all those things lead to complications which end up putting people in hospital and then filling up all the beds.
So we've got fewer going to become GPs?
Well, I think one of the issues is we don't have enough GPs for the population. I think one of the big issues which I talk about is the way GPs are funded. There's a lot of extra work that they do, which is not really captured in the funding. They get funded, GPs half run as a private service and half funding from the government.
Yeah.
And they get paid they get funded based on these capitation rates, which are based on how many enrolled patients you have in the practice. What they don't account for is how complicated those patients are, or how much work you actually end up doing with them. And they don't really take into account all the extra work that GPs do that is not patient-facing. So all the time in your lunch breaks and your evenings spent filling referral forms, chasing up letters, chasing up results, filling out ACC forms, all this kind of paperwork, which they're not really that funding doesn't capture all of that. And so the GPs kind of go, well, we're getting burnt out here. I'm going to leave. GPs are leaving the profession. There's quite there's a big section of the GP population who are nearing retirement age. Then you have less GPs. That puts even more pressure on the system.
Yeah. And that wonderful, I remember, my daughter's like 38 now, and I remember when she was, certainly, it was under 5, and they worried that she had whooping cough. And her GP used to call me twice a night to check, because he was obviously undecided as to whether or not he should have sent it. We went, and it turned out it wasn't, but he was obviously worried, and was worried about the call that he was making, because you're always making those sorts of calls, right? In his time, from his home at night, he would ring to check on her, and I just found that extraordinary.
Yeah, and I think that captures the practice environment that GPs work in. I think I talk about in the book. Being in intensive care is actually relatively easy, because I can leave not leave, but I can, go to sleep when I'm on call, and I know that patient is there being watched by a nurse and other doctors, and we can pick up on things straight away. GPs working in an environment where I think I talk about finding that needle in the haystack. So which of these 10 babies who come in with which of them have a cold, which is the 1 out of 10 that has meningitis or whooping cough, who am I safe to send home, who I don't need to send into hospital. They work in a really uncertain environment, and I think that adds a lot of...
And in 15 minutes.
Yeah, and in a 15 minute...
They're expected to kind of get the history of read notes, make that kind of call, and we do definitely put a whole lot of pressure on them. So with the sort of funding argument, not just for GPs, but across the whole health system, is it because if others were sitting here, they would be saying that we're just not spending the right money in the right ways, in the right areas, and on the right people, effectively. Because you must see a lot of waste in the system as well.
Yeah, I mean, I guess there's inefficiencies in something as complicated and sprawling as healthcare is. There's always inefficiencies. I guess what we see is that not just the population, there's more demand, but the things that we're actually offering to people are getting more and more expensive in advance. So I make an example in the book. If you had a stroke in the 90s, you got an aspirin and a pat on the back and good luck. See how it goes. In the 2000s, this clot-busting drug came out, and now every stroke's become an emergency because if you give that clot-busting drug within 4.5 hours, you can kind of result in better outcomes. And in 2010, they started introducing a procedure around that time, a procedure to then be able to actually go up into the brain and pull out that clot that was causing the stroke. Suddenly that's an added aspect to it. And then that initial time period for that to happen was also 4.5 hours. Around 2015, 2016, maybe later it became 24 hours. So over this short period of kind of 20 years, all these new expensive treatments have come out. So it's hard to, there is always waste, but when you have more people who need health services, more expensive treatments we're providing, and funding for that's not keeping up with all that, it's hard to, I think you need to make sure you give enough before you then go on and say, well, actually, it's hard to judge people being inefficient when actually they're kind of just scrounging to try spend it where they need to.
Can we talk a bit about that private and public health care and how it crosses over? And certainly we're hearing at the moment, about, politicians are talking about more being able to be done in private than in health. Actually, just as chairing Pharmac, the Cabinet came out with a decision during the budget that from now on cancer treatments that we fund, of course, because they used to, if they were in private care and we then funded that cancer drug, they would have to go into the public system to get it. And ministers have just made the decision that actually now you will be able to get access to that medicine within the private care, which means that hopefully from the patient's perspective, they're getting a continuity of care that makes sense. But most of your specialists in particular work in both, don't they?
That's right, yeah. There's this kind of idea that there's these two separate systems, there's public and there's private. Really, there's a small minority of people who will just work in one or the other. For example, intensive care, there's no real prospect for private, so I only work in public. But the majority of specialists out there will split their time in both, and so when you go to see someone in private, it's probably the same doctors that you would have seen in public, you just see them faster. Yeah. You're
just seeing them differently, in a different environment and that sort of thing as far as that works. So do you think it works? You sort of give an example in the book where, someone's, sort of on call and they're working in the private system and, is that essentially double dipping, that they're actually getting paid by the public system and getting paid at the private? I get when it's separate, I do this job on Monday and I do that one on Tuesday, but when you're sort of on call on a Monday but you're actually in your private practice, does it seem like that makes sense?
Yeah, that's definitely double dipping, and that's definitely, I think that's the chapter where I talk also, there's those two patients, one of them who's been waiting a year to get an investigation in the public system, and in the meantime she faints because of the underlying problem and then she breaks her arm, and another patient next door who's had all these tests done in the space of 3 months, which you never would have dreamed of getting in the public system, and it just feels very unfair. It feels very unjust, and I think it also feels unjust. And I've had situations where you are trying to get in touch with the specialist who's on call in public, and they say, well, I'm not available till after lunch because I'm in private. And I think that's clearly double dipping, and that's not right.
With that private public, I get that some people are getting treatment because they can afford it, but is that not freeing up the public system as well?
I think the key message in that part of the book is that because it's all the same doctors, the same people splitting their time amongst public and private. I don't know what the solution is, where the true balance lies. But I think anything that we talk about, and there's been a lot of talks recently about moving some of that offloading the public system by moving it to private. I think when you talk about stuff, the things you have to, I talk about the reason that some people are able to get faster care and seen faster and get more tests done is because that system is exclusive. But at the end of the day, it's all a zero-sum game. So anything that you move out of one system into the, anything you move from public into private, there's no extra capacity that you can just magic up from somewhere. It's all a zero-sum game.
Yeah.
So if you move a lot of services into private, that requires more time for specialists to be working in private, and that takes those specialists away from the public system. So you kind of have to give with one hand and take away with the other. in some respects.
Sometimes in pharmac they say to me there's no such thing as freeing up a bed. Because I'll go, well, which we've done, if we fund Keytruda for more, that means that there may be fewer operations, lung transplants and things like that, and so that's freeing up beds. And they say there's no such thing because that bed's full. There's someone else waiting for it. You talk about that inequality, for want of a better word, and I'm using that word, not you, but and not just in that public and private healthcare, but equally the illnesses that we've got going around because of poverty. I always used to think that housing and the quality of housing would be one of the best thing we could do for everything, quite frankly. How can you look after your health if you are in a cold, damp, how can you actually think about getting a job if you are worried about where you're going to sleep that night, and you're probably not going to be able to because the kids are so sick that you're not going to be able to fulfill, let alone get, we talk about education and kids going to school, getting housing actually right for people just fits right across. And we can all, you sort of talk about that personal responsibility versus, kind of just life's blows and how it hits you and how you react to it. Can you talk a bit more about that and that inequalities that you see and what you think, what the outcomes for these kids are really?
Yeah, so there's a chapter where I talk about that, where I'm a medical student on placement and I'm visiting with a social worker to go see a family in South Auckland. It's a cold winter's day and it's all kind of very dreary, and you walk into this house which is just absolutely freezing, like it's just an ice block.
Yeah.
Now this was in 2014, so it was kind of before the healthy homes stuff came out, and then you look and there's black mould on the walls. And, you're talking to the social workers, talking to the family, and all the kids have been in and out of hospital because they've been getting sick. And then I talk about the one child he's had open heart surgery because he's had rheumatic fever, and all these illnesses, the rheumatic fever, that's all a consequence of living in these homes which are substandard. And I talk about the things that make them, and it's just really cold homes that are hard to heat up in winter. People crowding together, people getting sick, and all. So it has a huge impact. In terms of, in terms of the demand of kids having to go to the GPs, then ending up in hospital multiple times, and then things which are like rheumatic fever, which are a direct consequence of that. So when you have to huddle together and living in a cold house, you're more likely to develop this infection called Group A strep, or strep throat, basically, which then is a rheumatic fever as a consequence of that, and that has lifelong consequences for this child who's had open heart surgery. That's going to something they'll live with for the rest of their lives and often is when they grow up to be adults, they have complications of their heart surgery. They might have to go in for repeat operations. So, and
if they live, right? You told the very sad story about Angel that's just 16 and, and doesn't make it. Okay, we're going to do it's not a quick fix. I'm turning to the pages of the book though, because we've got to do it, right? Yeah. So let's go through this because we've got to get it right. So we need more registrars, more specialists, more nurses, more wards, more operating theatres and clinics and better IT. IT is huge, Isn't it just ridiculous?
Massive, yeah. At the start of the book where I talk about the chapter on Whakaari, and we have all these patients coming in from various hospitals, and we still don't have a unified IT system. So you can come from the Waikato to a hospital in Auckland, and I have no idea if you've been transferred. I have no idea what blood tests you've had. I have no idea what scans you've had. I don't have access to any notes. It's all it's completely disjointed. Yeah. It just doesn't make sense at all. The shortage of doctors. We've heard this for years. Do you think it's improving and that we're seeing more come out? And then if it is, then how do we keep them in our system? Yeah, I think the problem we have with doctor shortage is something that is a retention problem. The Medical Council publishes these stats every year about our workforce, and we've seen for most of the 2000s, we've been able to actually retain more doctors. In the last 5 years, there's a graph which shows suddenly our retention has dropped off massively. And so all our doctors... What would you put that down to? Well, I think it's twofold. I think, first of all, the conditions are better right across the ditch. In Australia, people make more money. They can kind of afford a higher standard of living. And here, for example, we're seeing with the recent senior doctor negotiations, the salaries here are not keeping up with inflation. I think the bigger issue that I talk about, though, is when I graduated medical school, there were more of us graduating than there were jobs for us. That's been the case before I did that, and also since I've graduated, that's also been the case. The problem is once you graduate medical school, you're an intern. Yeah. To then go on to become a specialist, you need to gain yourself a specialty training position. And at the moment, there's a bottleneck of those. There's not enough funded training positions. We also have no idea how the number of positions gets decided, because it gets decided across an Australasian kind of level. Yeah. And so what you're seeing is this bottleneck. If we have all these junior doctors entering the system and a bottleneck of the amount of training positions they can get into to then produce specialists on the other side, people go, well, can't get a training position here, I'm going to go overseas or somewhere else where I can get one more easily.
Wow. How much do you think that the pay conditions for our professionals is a factor?
I think it is a factor. I think the bigger I think, as you see in any job, there's the pay, but there's also the conditions you work in. I think if you had a situation here in New Zealand where there was more funded positions for trainees to get into to become specialists at the end, and if we had a health system that didn't wear you down at the end of the day, having you feel like you're kind of spent your day in the twilight zone, I think that would probably be a bigger factor in terms of retaining people than necessarily the salaries themselves. I mean, they're both issues, but I think the environment that you work in and the opportunities you have are probably, for a lot of people, would have a better effect in keeping them here.
Yeah. Do we need to put more into preventative care?
Absolutely, yeah.
Yeah.
I think, as I said before, the reason people are ending up in hospitals are complications of things that need primary care. And I think I said directly, one good GP can do more good than 10 intensive care doctors can do. Yeah,
very true. So how do you feel about writing the book? How do you think it's going to be received by your colleagues, if you like, or by your profession? You would have thought about that before, because it's very honest.
It is quite honest, yeah.
Yeah, it's a very honest book, which we appreciate. But did you think about how, that's going to affect you, perhaps?
I thought about it a lot, yeah. There's some parts where I think, was I too honest there? But in the end, I thought, I've been a little bit nervous about the reception. In fact, I held off telling any of my colleagues up until about a few weeks ago.
Oh, really? Yeah.
Everybody's been kind of quite keen to read it and quite excited. And I think overall, most people will resonate with the stuff that's written in there. But, when you're honest, you never know. If there will always be people who maybe not fans of what you say or disagree. And I guess it is coming out and, criticising my employer for a fair amount.
But you do say in the book as well that you certainly times that you've tried to address issues as you see them, they're pretty much ignored.
Yeah, it can be difficult to get any traction with anything. Yeah.
So, you say that you had given a lot of thought to writing the book and how it might be received. So why did you do it then?
Well, a couple of reasons. That the whole writing exercise started as more of a personal kind of journal almost, and because I enjoy writing. And then before I knew it, I'd written 20,000 words, which I was quite happy with. And that's when I submitted to the publisher. And I kind of thought, well, this is too good to just leave it sitting in a desk somewhere. But the other thing was I kind of thought about, well, let's say the worst thing happens and someone gets really upset about this and it affects me negatively somehow. That would just mean that what I had to say was even more important to actually say.
Yeah.
And so once I realised that, I just kind of thought, well, whatever.
So what do you hope? What do you hope happens now that you've read this book?
I hope with people having a bit more of a understanding from the ground level where all the problems lie, what things are really looking like, that people get passionate and just advocate from their leaders, politicians, or whoever for changes in the system.
I think a few people could learn to be a bit more respectful to each other as well.
Yes. That's also, that's also true.
I'm one of those over-grateful, elderly parents, so being in and out, one doctor once said to me, you can actually stop, it is my job, you can stop thanking me. And I was like, no, I don't think I can. I'm so incredibly grateful. So when we think about, our health system in the future, as you say, we're constantly thinking around medicines and medical technologies and what's happening and how on earth we keep up with the level of care that people expect, right? Let alone everything else and the cost of it. Can you see it improving? If you sort of, and some of the ideas that they've got at the moment and the changes that they're trying to make, do you think it is making a positive difference?
I think what I say in the last chapter is, even though I've called the book A Dim Prognosis, I think the prognosis is still reversible. It's just up to all of us. I think that there are a lot of things that I see which are people with good intentions and a lot of steps in the right direction, and people do really care and want to make things better. I just think that we need more.
Yeah. But even, I asked that question in the context of the whole health system, but, even one of the healthy homes, standards, you sort of mentioned that, and I sort of keep thinking, well, it's, as you say, it's probably a bit early, but let's hope that that's making a difference because we've got third world diseases here, right?
Yeah, I think that was, it's funny, all these, there's a lot of things that happen, they get introduced and that are really positive, and then, as you say, people forget about the good things, and even for me, when you think on the spot, it's hard to remember some of the good things that have happened that have changed things, and I think that probably is one of them. Yeah, but it'll be interesting. I think the compliance report or whatever comes out later this year, so it'll be interesting to see how we're tracking with all that.
Yeah, absolutely. IT systems that talk to each other would reduce a whole lot of admin time and actually mean that people are able to spend it face to face, which makes the biggest difference. So what's next for you then?
So I'm finishing up in my current job in August, and so that's when I finish my training, and I'll be a fully qualified specialist at that point. And then I'm going overseas for a year.
Okay.
To the UK, which is like doing a fellowship. So it's
just for a year?
Just for a year, yeah. It's a pretty...
well, how am I going to know that you come back? Because you see, we can't afford to lose you. That's the point.
I'll promise I'll come.
Okay, there you go then. I'm all right with that. Okay, finally for this segment, I would love to know what was the best advice you were ever given and who was it given to you by? Best
advice? So it's funny, so because to prepare, I'd listened to a lot of your previous podcasts and stuff, and I knew that was a question that seemed to come up a lot, and so I thought, I better find some good advice.
You better find some good advice.
So I asked a friend yesterday, I said, I'm sure I've had good advice all my life, but it's just hard to think of stuff. And so, do you have any good advice? And he gave me something which I actually thought was really, really good. He said, through his life, everybody has various balls that they're juggling and trying to keep up in the air. And it's different for every person what those are. But he said some of them are rubber balls, which if you drop, eventually they'll bounce back and you can keep on juggling. And other ones are made of crystal, and once you drop them once, that's it, they're gone, and you just have to figure out what are the things that you're juggling are the rubber balls and which are the crystal balls. Yeah,
sometimes it's kind of another way of sort of don't sweat the small stuff, like it'll come back, and maybe this week I'm not spending as much time on X that I would like to, but I can exercise more next week and actually pick that back up. I just know that it's because it's busy. Yeah, I think it's a really good one in trying to work that out. Okay, Ivor, the podcast is called Ask Me Anything, and so, as you know, now this is where you get to turn the tables on me. So this is your opportunity to ask me anything.
Well, I was quite interested. You started in FIMAC, was it?
A year ago. Yeah.
What's been the most surprising thing about being in that arena?
Well, it's not surprising, but as you can imagine, those incredibly clever people that are really on a day-to-day and in the jobs because they do want to make a difference. They sincerely want to be funding as many medicines and the right ones for the country that they possibly can. And in that context, they're literally trading off, like you're talking about budget. So within such a restricted budget, they are literally having to make those sorts of decisions. And you know it from the outside, but I suppose it's that getting to know the human and the humanness of them. And of course, they get a bad rap, have in the past. And I think I've been hearing great things about that culture is genuinely turned in the last sort of 6 months in particular. But you can kind of understand why they retreated, and I don't think I did understand that before I went in and met them. You're sort of saying no more than often than saying yes it can feel a bit thankless at times.
Yeah.
And even in the last 12 months since they did get their funding boost last year for those cancer drugs, so they've funded an extra or widened access for an extra 63 medicines, which is pretty extraordinary in such a short period of time. And they made one kind of mistake, if you like, on the consultation of HRT and patches. Which if you're going to if you're going to upset anyone, don't upset menopausal middle-aged woman, right? I mean, I totally get that as one, but I felt so bad for them that they did 63 things right, at least, and they get blasted for the one they slightly got wrong.
Well, it's that blindness, right? Like everybody looks at all your mistakes and doesn't.
Yeah.
They don't care about the
hospitals
things.
And things are amazing though with the medicines that they do and how they do it. Yeah. I just think doctors and that medical profession are probably the best. But man, watching, because of course we've got clinicians that are assessing whether or not we're doing medicine, and I've sat in the room with 22 of them debating about about this medicine versus this one is quite something to sit there and watch. Fortunately, I have someone very smart next to me that literally translates it for me.
Yeah. It'd be fun to be a fly on the wall and listen to them argue about their opinions about each thing.
How high is the need, and as I say, I mean, we've got 161 medicines on the official list at the moment, which means we want to fund all of them, and you don't have the funding for it. Which you would understand. Okay, Dr Ivor Popovich, thank you for your time today and for speaking out and for writing this book. And I hope that a whole lot of people read it and they get the complexity of the problem, but then also it's the classic, how do you eat an elephant? And it's one bite at a time. So I call it continuous improvement. And we've just got to constantly be checking ourselves and asking ourselves what we see to be the main response that we need. So thank you. Thank you for coming in.
No problem. Thanks for having me, and it's been fun.
Good. Okay, so Ivor's book, A Dim Prognosis, Our Health System in Crisis, and A Doctor's View on How to Fix It. It's in stores June 17th. So go and get one and have a read. And that's it for another episode of Ask Me Anything. If you've enjoyed this episode, please follow Ask Me Anything on iHeartRadio or wherever you get your podcasts. Make sure you check out some of our past fabulous guests while you're there. I'll be back next Sunday. I'm looking forward to it. I'm Paula Bennett. Ask Me Anything. Goodbye.